this is a topic, something we do see fairly frequently, or at least with a thought process about this in the ICU. And it's a lot of the management of these cases is supported, and then a lot of it is about the specific cause. So today we're going to go through these topics quickly, just the definition, some anatomy and physiology, some patterns of liver dysfunction, causes and diagnoses, and then some management. So it tells it. So I'm actually glad it's here. This is a great time. Okay, so for the definition of acute liver injury, it's a severe liver injury with impaired synthetic function, altered mental status without cirrhosis or pre-existing liver disease, and it occurs over a duration of less than 26 weeks. This has always been an amazingly long period of time to call something acute for me, but that's how the structure is broken down: hyperacute within 7 days, acute 7 to 21 days, and subacute is 3 to 26 weeks. So just to know that even if this has been brewing for a fairly long while, it can still be considered an acute liver failure. And we'll go through what each of these little things mean. But here's a few classification systems taken from an article by Grady et al. And you can see the different classification systems that are used across the world. The Japanese have a slightly different approach to classifying liver failure. In terms of the histopathology, this is just something that's very important to understand. So this is effectively taken a biopsy of the liver, and we're looking at a cross-section at the level of the hepatic lobule, these hexagonal structures that make up the liver parenchyma. And you can see that they're at each corner of the hexagonal shape, there's 3 structures called the portal triad, a portal vein, a hepatic artery, and a bile duct. And in the middle of each of these hexagons is the central venule, or central vein. So it's just important to know which way things are flowing in this structure. So blood flows from the portal vein and the hepatic artery, the portal vein bringing with it all the nutrients and things that have been digested from the GIT to the liver for management, and the hepatic artery bringing oxygen from the heart. So that blood flows through the sinusoids towards the central venule. Central venule then links up and becomes lobular veins, and then into the circulation to go back into the IVC. So bile actually runs almost in the opposite direction, but you can see that the way the bile flows from the center of the lobules to the bile ducts and out into the GI system. The hepatic acinus is then a functional classification of zones within the hepatic lobule, and there's 3 zones. The periportal zone is zone 1, and then the zone that's the highest risk of ischemia is zone 3, because it's the furthest from the blood supply. And that becomes important when assessing the patterns of liver dysfunction and understanding what we see on our blood tests when you get a raised ALT or a raised AST, and the reversed ratio between those. You can kind of understand where that's coming from. So I like to have this picture in my head when thinking about liver failure. Patterns of liver dysfunction mean it's very easy for us to look at a blood result page and see, sheepers, that ALT is super high or that ALP is super high. But sometimes we do get caught out calling something a hepatocellular dysfunction when it is actually mixed. So the R factor is then a little equation that you can do. So it's the patient's ALT divided by the upper limit of normal. We use 40, divided by the patient's ALP divided by the upper limit of normal, which is 120. And if you get a value that is more than 5, meaning the ALT is predominantly raised, then we call that a hepatocellular picture. If the R factor is less than 2, we call it a cholestatic liver injury. And if it's in between, it's mixed. And this is important for determining possible etiologies of the liver failure.
It's somewhere in empty calc, I presume.
Yes, it is. It is. So the physiology, so liver has a few functions. It's got some synthetic functions, and those synthetic functions are important for creating albumin or other binding proteins that flow through the blood and carry proteins around, carry hormones, carry your drugs. So important to know about that. It also is responsible for the majority of your oncotic pressure. If you think about the forces within your or across the semipermeable membrane, oncotic pressure is a significant one, a major one that determines whether or not fluid moves across the semipermeable membrane. So the liver is responsible for creating coagulation factors, important for clotting. It's important for gluconeogenesis and glycogenolysis, creating energy for the body, and also for beta oxidation, which eventually comes into that energy creation pathway as well, just via a different path. So what defines synthetic dysfunction then? The three elements are an INR that's greater than 1.5, an albumin that is low and dropping, and a low glucose are the three elements of synthetic dysfunction. These are some causes of liver failure, and you can see that there are many, and this list is not nearly exhaustive either. There's a lot of stuff going on, and you can break it down into carrying the team there. So there's many different groups of causes, and it kind of helps to break them down into these little sections. But the stuff that we see most often are these. Toxins, we often see paracetamol toxicity, viral hepatitis, hepatitis A and hepatitis B, sometimes hep C, TB treatment and the other idiosyncratic drug reactions. So a DILI is the classical one from TB treatment. And then hypoperfusion and a shocked liver. And that also includes sepsis as a cause of shock. So if you're getting poor perfusion to the liver because of poor cardiac output or decreased systemic vascular resistance because of shock, then that can cause ischemia in the liver. And then there's also hepatic venous occlusion, which we do often see from heart failure. And then other causes can be like an IVC syndrome with a clot, or the rarer causes of veno-occlusive disease and Budd-Chiari. I don't think there's any obstetricians here, but fatty liver, acute fatty liver of pregnancy is a cause for them to be aware of as well. We do have a few autoimmune hepatitis patients floating around in the MOPD system as well. Yeah.
Probably will come for palliative care.
Yeah. So, clinical features of liver problems. I think it's important to think about these three groups separately because they don't always coexist, and they imply different things. So when you're examining a patient, there's features of chronic liver disease, you can see features of portal hypertension, and you can see features of liver failure. And the patient may have features of chronic liver disease without features of liver failure or portal hypertension. So just important to know that these are separate in their presentation on the patient and have different causes. But chronic liver disease, some features you can look at clinically. You can see the patient's got palmar erythema, if the patient's got gynecomastia in males, spider nevi or telangiectasias on the chest wall, testicular atrophy. A lot of those are to do with hormonal associations, so actually raised estrogen levels from the chronic liver disease in males, but also in females. So you can get the spider nevi and the palmar erythema as well in women. Portal hypertension is then a consequence of some liver diseases. and that presents with caput medusae, so the big distended vessels across the abdominal wall, and they drain kind of you can look on the patient and kind of see which way the vessels drain to help decide if that's pathological or not. Splenomegaly is also then a cause or a sign of portal hypertension. If the patient has varices, I know the surgeon's nightmare, upper GI bleeds of patients with varices, and then hemorrhoids as well. And these patients also, of course, can have ascites. And then the features of liver failure, which, if you think about it, are the functions of the liver we spoke about earlier. These are clinical manifestations of that. So if a function of the liver is creating clotting factors, then bruising or bleeding could be a feature of liver failure. If creating albumin is a feature, then edema is a feature of liver failure. Hypoglycemia, glucose, and then encephalopathy as well, because of the liver's detoxifying function and the buildup of ammonia in the system. So our major concerns in the ICU when thinking about patients with acute liver failure, the first one is hepatic encephalopathy and cerebral edema. Secondly, sepsis. Thirdly, coagulopathy. Fourth, renal failure. And then also the fluid and electrolyte management of these patients becomes complex. General management of these patients, there's a little grading of hepatic encephalopathy there on the right, but I've got a better table coming up later. But where to put the patient is important. And any patient with grade 2 to 4 hepatic encephalopathy should be considered for ICU. I think in our setting, it's sometimes difficult to put the grade 2 patients there, but we do try. There's obviously taking this information mostly from UpToDate and other first world guidance. They require, or they put as their suggestion, serial monitoring of labs at like unbelievably high rates. They say like, 2 hourly INRs and stuff like that, which I don't think is possible in our setting. So, but just to understand that we should be monitoring our patients serially, and that would be related to those functions and the features of liver failure as described earlier, but also looking for complications. The patient may require some fluids if they initially intravascularly depleted. So you can consider giving normal saline or dextrose containing fluid if they're hypoglycemic, or if the patient is hypotensive, they may require some inotropic support. And the difference here compared to normal targets is we might target a higher mean arterial pressure than in other instances, given that we want to maintain the cerebral perfusion pressure between 50 and 60 millimeters of mercury, understanding that these patients often get cerebral edema. N-acetylcysteine, Parvalex, is a really good drug. It's a bit expensive, but it's not only for paracetamol overdoses. There's some evidence that transplant-free survival is significantly better for all causes of acute liver injury. This was published by Leotal in 2009. So you don't have to use N-acetylcysteine only for paracetamol overdose. It can be used in other causes as well, with the understanding that you're going to be giving it to an acutely unwell patient. They may or may not be fluid overloaded, and N-acetylcysteine usually requires a lot of fluid. And then also in our context, it's not a cheap drug. So just to think about these things as well. And then bleeding prevention in these patients, knowing that the INR, because it only measures one arm of the clotting cascade, is not entirely predictive of bleeding. Prophylactic FFPs are not generally advised. And then PPIs or histamine 2 receptor antagonists are advised for management of the prevention of bleeding in these patients, specifically patients who have varices as well.
What's the vitamin K?
Yeah, I thought you were going to say something about vitamin K.
Yeah, so if there's from reading UpToDate now, they're saying that if there is concern for bleeding, then you can give vitamin K as well. But
I think the evidence is that doesn't really
Yeah,
help
It's-
because
there's
you're
no-
doing synthetic dysfunction. So if
Yeah.
you've got vitamin K depletion, then
Exactly.
that addition isn't going to
yeah.
make a difference.
So you're trying to bank on the remaining functionality of the liver, but it's not like if this person's really got diffuse fulminant liver failure, then you're saying they probably don't have good functionality there.
But just as something else, John, is that the bleeding tendency, because even in cirrhotic patients, there's still risk of thrombosis, which
Yes.
all the chronic factors are down, even the. So it doesn't mean that they are not at risk of getting a thrombus. This is the problem. So you never quite know, should you anticoagulate them and at what level? I don't know if you maybe read any guidance on that, because that is difficult.
Yeah, I haven't done anything further in terms of chronic liver failure now. But yeah, it's, I think, something to be aware of. And it's difficult to measure that balance as well, because our tests are imperfect. Yeah. Another aspect of general management of these patients is with relation to infection. And I also realized I had a kind of an imperfect understanding of this approach. But in acute liver failure, it's more about screening and prevention and early detection of infection rather than giving prophylactic antibiotics. So there's no clear indication for prophylactic antibiotics. There's studies that have shown no mortality benefit, not just studies, but randomized controlled trials and meta-analyses of those trials. There was one study that showed lower rates of bloodstream infection, but it didn't translate to an overall mortality, and it was a secondary outcome as well. So all our patients who come in with liver failure should be actively screened for infection. That means urine, blood, sputum cultures, chest X-ray, to try and identify possible sources before it becomes an issue. And we do have a lower threshold then for initiating empiric or direct treatment. So if the patient comes in, and Johno had a patient overnight who was in severe liver failure, and the thought process was that there is sepsis could be a significant factor here as a cause of this acute liver failure, then we'll treat for that thought process. But prophylaxis to prevent infection is not advised. The difference being that in someone who does have cirrhosis, a chronic liver cirrhosis with ascites, who then comes in with an infection or a decompensation of their liver disease, we might cover them with ceftriaxone and ampicillin to cover for possible spontaneous bacterial peritonitis. But it's a slightly different group in terms of your thought process. Lynette, sorry. I want to get your input on the nutrition, because that's the evidence I found on UpToDate.
That's what we said
Mm.
before. So
Yeah.
I remember the last patients that that you effectively we've been talking about now, but
Yeah.
actually the new information set is saying the exponent national guidelines is saying that definitely 1.2 to 1.5 grams of protein, grams of protein per kilo. So that is what we will.
Yeah.
So we're not going to according to a low protein.
Yes. Yeah. Okay.
Sometimes if there's maybe something like ascites or something, it's still a little bit low, and it just goes start some water up to 1.
Yeah. Okay. Cool. Yeah. So I think that's a bit of a change in the thought processes, at least. I mean, I might be just behind on that, but initially my thought was, protein load and ammonia. So it's interesting to know. Okay, so treating some specific causes. Paracetamol overdose, we do have a unit protocol on this, and it's kind of in the process of being looked at again. But basically there's indications to treat with N-acetylcysteine, and it's if there's a normogram that shows a 4-hour level above the treatment line, any ingestion more than 7.5 grams, any unknown time of ingestion with a paracetamol level more than 66, any liver injury regardless of the level of paracetamol, and anybody who's got a high risk of liver damage. So basically, when in doubt, treat. If you're not sure, the patient's confused, just treat. N-acetylcysteine is given according to that protocol, but we can kind of concentrate it a little bit more if necessary. The viral hepatitis, there's a little bit of controversy in treating Hep B, but the use of antivirals or direct antiviral therapy is usually not advised in acute Hep B, because 95% of immunocompetent patients will recover spontaneously, and rapid suppression of viral replication may impair the body's ability to create antibodies to the virus, and hence predispose the patient to developing chronic relapsing infection, which is not something we want. We want the person to clear the infection, with the understanding that what we usually see, the effects, the liver failure, synthetic dysfunction that we see in acute hepatitis is a result of the body's immune system targeting those infected cells. So in that balance. So therefore, it's only indicated if there's very severe disease. And I mean, INR of greater than 2 was a surprisingly low number to classify something as severe disease for me. And if there's encephalopathy, and they didn't say what grade of encephalopathy, just said encephalopathy. If the patient is elderly or immunosuppressed, and if the patient has a Hep A, Hep C, or Hep D co-infection. And then there's just a small block there on hepatitis A, which we do see occasionally, and there's no clear direct management. It's all supportive with strict bed rest, barrier nursing or isolation if the patient is fecally incontinent. But if they're not, then they don't have to be isolated. And you can return to work only once the patient's ALT or AST is less than 100. Because if you do put stress on the body before that time, they can get this relapsing process, and it drags on for months then. HSV is another viral cause, and I guess we're just going to add the acyclovir as part of the regimen there. Acute fatty liver of pregnancy, we're going to deliver the patient, and then we manage the complications. So the grading of hepatic encephalopathy is here, grade 1 through 4. Grade 1, they can feel euphoric or depressed, mildly confused, slurred speech, some disordered sleep. They may or may not have asterixis. Grade 2, lethargic with some moderate confusion. Grade 3, marked confusion. And grade 4, coma. Obviously, if you've got a coma, you're not going to have an asterixis, but the other two, you will have a hepatic flap. So the patient goes like that. Yeah, and then in the first world countries, or if you've got the resources available, then EEG monitoring can be done as well. This is how hepatic encephalopathy comes about, and it's really multifactorial. You can see that it's actually a poorly understood process, and it's not just raised ammonia means confusion. The high ammonia levels from the GIT means that glutamine glutamine in the system is broken down into glutamate plus ammonia. And this can impair CNS transport of amino acids, increase intracellular osmolarity in the astrocytes, which are like little workers in the CNS, alter the neuronal electrical activity, buildup of oxindole, and increased oxidative stress in the CNS. And there's also elements of impaired neurotransmission. So GABA, neurosteroids, histamines, glutamate, serotonin, catecholamines, all are affected by that. The brain's energy metabolism is then affected because of hypoglycemia and the ammonia itself. And then there's the systemic inflammatory response syndrome and neuroinflammation as well that all contribute to this effect. And I think there's a lot of understanding that's changing, not just in liver failure related to encephalopathy, but all these multi-system inflammatory illnesses, that the inflammatory response is responsible for so much of the other organ dysfunction that we see, hepatorenal syndrome or cardiorenal syndrome. There's all these different inflammatory systems that are dysregulated in these conditions. So management of hepatic encephalopathy, monitor the patient's GCS. We don't do ammonia levels, but can be done. Treat the fever, so targeting a core temperature of about 35 degrees Celsius. Endotracheal intubation if the GCS requires. And ventilating the patient to target a PCO2 of 30 to 45 millimeters of mercury or 4 to 6 kilopascals. Lactulose is not used in liver failure acutely. There may actually be worsened outcomes in acute liver failure, but you can use it in chronic hepatic encephalopathy. And then the major complication of this is cerebral edema and raised intracranial pressure. We don't have ICP monitoring and transcranial Doppler, but that is the gold standard. And then preventing raised intracranial pressure to keep this target sodium between 145 and 150, so a little bit on the high side. Closely monitor the patient's fluid status and nurse them 30 degrees head up. And then treating the raised intracranial pressure, we can use mannitol 0.5 to 1 gram per kilogram, can use hypertonic saline, can consider barbiturates, indomethacin, and hypothermia, but there's no really solid evidence for improving, survival outcomes once you get to this point. It's more grasping at straws, trying to keep the patient alive. But it usually is kind of the last straw in that order almost of things to try. If the patient does have seizures, phenytoin is considered the primary agent, and then only to use short-acting benzodiazepines if the patient is refractory to phenytoin. Acute kidney failure, we want to obviously try and prevent this, so avoiding nephrotoxic drugs, monitoring and correcting electrolyte abnormalities, monitoring the patient's fluid status and blood pressure, and then treating and surveilling for infections. We very rarely have access to renal replacement therapy in the ICU for these cases, and especially not the continuous like CVVHD or something like that. It's very rare that we'll have the ability to get this for our patient. And a lot of the information that I found online from UpToDate and other first world countries is around this part of treatment and getting towards transplant. And liver transplant is then the last step in this process. And I think that the bottom line is just ask, because we never know. But I don't know when last we managed to. We haven't had one. I don't think that we're qualified, but it's just
reality is there's no chance of acute transplant.
Yeah.
That's reality. I mean, so I don't think any of our patients will make it.
Yeah.
I think there's so many livers and such a shortage of livers in South Africa.
Yeah. We all die with short livers. But yeah, there's a few interesting little insights on this table, and I think looking at the age there's, I think, something that's really strict even out of a first world country. So yeah, just something to consider when talking about liver transplant. And that's the topic.